this is more informational, but I wanted to throw a little shout out to FDA and make you aware of a resource that will be available to this and other communities. And that is a training curriculum on model-informed drug development that was originally created from a grant from FDA to the Critical Path Institute. And it's targeted to a non-modeling audience, but it's really a wonderful progression of topic areas related to model-informed drug development with a lot of tailored examples. FDA members, including Chilu and Raj Majabusi, were part of the steering committee, so it's got a strong recognition in terms of hitting the mark in terms of regulatory decision-making. And I think, well, I know FDA is committed to making it globally available to the research community. So this could be another asset for this community as well. I would say, make a plug too, that I think a nice complement to that would be a place where actual, in addition to didactic training, hands-on training on computational tools. Because in addition to the redundancy around training materials, everybody's buying a license to very expensive commercial software. Wouldn't it be great, particularly for training purposes, if it was in one place? And since we're all contributing a small amount of data, make it available to a broader community, particularly those who are trying to train in this area. So I just put in a plug for that as well. Thank you.
So I think that sort of points to some challenges with training. I guess we'll have a whole session on training, but I think access to resources and access to access to software, access to expertise, I think are all key challenges that we can learn more about how we can facilitate this. It looks like Elimika, did you have a comment? Okay.
Not a comment, but more of a question. I would like maybe to hear, we heard in the presentation earlier around diversity and from people working in the various networks. How are you looking at that in terms of your plans, and how are you measuring it? And then, and maybe also NIH colleagues can say how they're measuring how that diversity component is being captured. Specifically, there maybe like a Native American communities that maybe are in different hospital networks than some of the centers you're in, and whether you've tried to leverage some of those communities in any of the work you've done.
Well, I'll start. So our clinical project is a randomized trial of an educational video on knowledge and attitudes on pharmacogenetic testing, and we specifically are targeting groups that are underrepresented in studies. So primarily racial minorities. That's how we're measuring it in that regard, and also children with children and their parents. Where the children have chronic diseases. And so our first step in that was a community engagement studio where we actually did focus groups with members of those communities and asked them how we can better recruit those populations specifically when we designed the study. And so, and that's the publication that Zasha was talking about. So we published a tutorial on that community engagement. We have not gone outside of our medical center to populations that might, for example, take Native Americans, but that's how we've approached it.
So I know she just came into the room, but Tina, I'm going to put you on the spot. There was a question about diversity, and I think that your work in the reservations, and I think in that arena, I think is really poignant.
So yes, we do have had a 10-year collaboration with the tribal communities in San Diego on pregnancy and lactation, primarily focused on substance use, but generally speaking, I will say, though, in terms of the human milk biorepository, it's an effort that we've reached out to Georgia to get consultation through NCATS to help increase diversity. And we've taken some action to try to do that because the sample now tends to be higher socioeconomic status white.
And I will just add that I think this gets to the point that was brought up earlier about community engagement, which I don't think we've actually gotten to in MPRINT. And that I think it's our responsibility in MPRINT 2.0 to have a community advisory board and to understand what are the needs of our community, especially if we're casting a really wide net and it's not disease specific, to really understand what our community wants from us. And I think that of course builds trust, and then it gets to the issue of being able to serve our communities. I mean, in San Diego, at least half of our families are Spanish speaking mostly, because we're a border city with Mexico. But I think that there's a definite opportunity there, and some of our investigators have that expertise. But I think we could definitely expand that much more.
Yeah, I'm not gonna for the MFMU. I'm not a speaker for the MFMU, but then with there's diversity on multiple fronts. If you want, there's geographic diversities of site that are strategically positioned to capture underrepresented patients, as well as diversity among investigators, diversity among staff, research staff. At our site, we do special training for all staff. And then it's tracked by year enrollment numbers, and then it's making sure you enroll people of different ethnicities and race and different other backgrounds, geographic locations, urban versus rural, and so that's at least for our site and others. Plus, there's the community engagement board at the MFMU, which is new with this cycle, and Nahida can talk more about it.
Yeah, so we're trying to center the community in everything that we fund, and so it started with the sepsis work that we had, and having a community engagement board up front with everything that we are funding. The MFMU adding the community engagement board to review protocols, to review concepts, weigh in on consents, on outcomes of what is really what the PIs want, what the community and the families want as potential outcomes that make sense to them, and that would be of highest priority. The centers of excellence have to have 3 components to them. So one is the project, but the project has to have had community partnerships from the beginning, from the onset of the project. We have a community component that is funded, as well as a training component, and the projects had to be focused on the needs of the community that they are serving. So it's unlike the networks where it's one project across the network. Each of the centers have their own projects that is focused on the communities of need. And we intentionally selected sites, obviously that scored well, but that were geographically diverse and included rural populations, included AI. So 3 centers are focused on AI-AN populations with tribal communities as their partners on the grant from the upfront. So centering the community is something that's really been a focus for us in the last few years.
Thank you. I'm happy to hear that. Just wanted to mention that this is an area, at least from the FDA perspective, that we're very interested in. And later this year, DPM, Division of Pediatric Maternal Health at the FDA is leading, is going to host a workshop on pediatric diversity. So very excited to hear at least broader interest in this particular topic.
Yeah, I have another, kind of my earlier case study in question was around kind of the beginning of a trial. How do you evaluate models, dosing, et cetera? Kind of jump all the way to the end. And this is something that came up. And I'm also thinking, what are some things that maybe the MPRINT could pilot or try out, over the next 2 years? So, one of the things that came up was outreach on once we get improved prescribing information, a label change, or information, roughly equivalent there. How do we communicate that to potential patients, right? And at various levels, not necessarily just to providers, although I think that's something to think about. So, I can imagine, within the scope of what the MPRINT can do, putting together some information, infographics, videos, et cetera. When you start to get into very detailed dissemination and implementation science, that I think is, that becomes, you need experts in that, and doing that is more expensive and costs. So I think maybe I'll direct this question to two people. I mean, one, Nahida, do you think there's opportunities there through the Improve Center? And then maybe Prince, if you could comment in terms of the community outreach studio at Vanderbilt, if it could have the capacity to evaluate something like that.
Yeah, so great question. And I think you hit it sort of the nail on the head. So implementation science, the reason why we developed, or the structure that we developed for the Centers of Excellence and having an implementation science research hub, is because most of the grants related to maternal health that we were seeing, most of the comments from reviewers were like, well, they needed implementation science research expertise. And we knew that because we wanted the diversity of the sites and to make sure that the patient population at highest risk were included, that we may have sites that may not have that expertise. And so we wanted to have that centered across. So I think it can be leveraged absolutely for any studies. And the site, so I'll say it's the University of Pennsylvania. So they have a really great model that includes a board, basically a disparities board that they've put together to look at all grants and make sure that they have that focus and the outcomes are equitable in any studies that is being done through the Centers of Excellence. So that's the lens that they're looking at. They have a depth of expertise in maternal health along the way. So the lead is an OBGYN. There's the MFM chair is sort of leading the board. So I think that, they really have a depth of expertise in implementation science research, especially for the population that we're talking about.
Yeah, and the community engagement arm, I'm more aware of their efforts to engage with the community in terms of research, but as you know, they sort of helped with the designing the educational videos. So I'm certain they have expertise in ways that we can design, or I should say, disseminate information to the lay public in a way that's understandable and yet doesn't quite dumb it down. I mean, it sort of explains it in a way that I think is appropriate. So I have not leveraged them for that purpose a whole lot, but I imagine they have that capability.
When speaking of diversity, and I'll let Rachel and maybe Sue Rahman speak about what we did within the BCA network, not only to analyze how we were doing, but then the ways that we can improve. But when working in pediatrics, as we discussed before, the recruiting center where you enroll that child isn't necessarily the place where that child lives. They can be hundreds of miles away. So I think of a matter of course, what we have been doing on most of our BPCA studies, if not certainly the big ones, collecting that first 3 number of the zip code to really understand our populations and where we're serving. And then those are, the important things to remember. And then again, going back, and Sue, I don't know if you want to talk, or I'm going to make you talk, to kind of explain how we've looked at ourselves and how we could do better.
I can start, but Sue's really the one that as a member of our PTN steering committee who's been championing this effort. But so we looked at the participants that were enrolled and compared to the population of the surrounding area where they live to kind of compare, are we are we preferentially enrolling certain groups more than other groups? And we're able to publish those results, which were actually pretty encouraging, with a couple of exceptions. And then knowing what the exceptions are, help us to try to kind of look at ourselves and figure out, okay, what's the next step to make sure we're doing a good job and giving these opportunities to all groups. Some of the things that we're starting to look at from our process standpoint are, what are the most burdensome aspects of a study? Are they more burdensome to some groups than others? Are there things in our inclusion exclusion criteria in our consent forms that are more likely to be acceptable to certain groups than others? Or are we, this came up in a concept that was presented recently at our steering committee. Are there language exclusions that we don't have to be making? And if there are, what is the reasoning behind that? And so I think there's always room for improvement if that's and having a steering committee with diverse perspectives was critical to getting that initiative going, and having someone who's passionate about championing it was also critical to that.
So I wanted to kind of build on that a little bit and challenge this group to stop thinking old style and start thinking new style. So for example, in the MPOX, the monkeypox clinical trial that we've written with the ACTG, we've actually moved from in-person consents to distal consents. And we've enrolled patients not at the mothership or any of the motherships. We've enrolled them in their houses, wherever they are, with a electronic consent. We sent them swabs, they swabbed, they sent it in. You had the monkeypox, we shipped you your meds. You never saw anyone at any of the motherships. You got your meds, you took pictures, you sent the pictures in, you cleared, we filled out, you never actually were seen by a clinical trial site. So that's number one. I think our current methodology, you have to go back to the mothership to get the consent, is really something we have to think outside the box a little. The second point is something that unfortunately we're still dealing with, Advera, which is the single IRB of record for many NIH clinical trials, right now still requires 2 parents to consent for enrolling on a child. So I don't know about you guys in the room, but my husband and I both work in completely different directions. And the likelihood that both of us will take off to enroll a child on a clinical trial is probably 0 or maybe lower than 0. And unless we get pushback from our NIH colleagues to Advera to say, stop this nonsense, 1 parent is sufficient to consent, or if you have that second one, it could be a telemedicine consent, it could be some, but requiring 2 parents to come in to consent for a child to enroll in a study is wildly unrealistic. So I think both from the distal consenting electronically to only 1 parent being there in person to nobody being in person, or 2 people needing consenting for a child, I think that we have to look at that next era of who, what, and where. And especially if you want to get diverse populations, on Long Island is very long. It's, hundreds of miles, takes 2.5 hours to get from the North Forks to Stony Brook. And I am not close to New York City. So, and we have a very huge migrant population that's working the planting fields. So the likelihood we're going to get 1 parent or 2 parents to come in to enroll the population is 0. And we've tried to get around that, had mobile vans and going out, consenting them in the fields and stuff like that. And sometimes it works, sometimes it doesn't work. But I think the driver of this has to be NIH, and has to be NIH talking to the SRB and saying, we don't think this is the way to go. You're actually putting a huge roadblock in getting diverse populations enrolled on studies.
I would agree. And I would say that we also build great studies for only children. And we don't think that mom or dad or whatever is dragging more than 1 child and occupying one while the other. And the rigor or the additional data points that may not be primary endpoint that, even FDA sometimes asks of us, we say it's not logistically feasible. We're not going to maintain enrollment, or they're going to come for 1 visit and say, never going to come back. So these are all the challenges we really see in younger children that you don't even have in an adult study.
But I think the messaging has to come from the study sponsor and say, we don't want this. We don't think you need it. And, don't tell me the FDA requires it. Sorry to my FDA colleagues here, because monkeypox is an IND study for a license, the whole thing, et cetera, and they're not requiring it. So they're not requiring it. I'm not requiring it. My institutional IRB is not requiring it, but the SIRB says, oh, we have to do it. Well, then who's their boss? And we need to get that fixed really soon, because this is a major roadblock. I did all the COVID vaccine studies for adults and children, and multiple machinations to get the kids in, and getting two parents to come in to enroll a kid on a COVID vaccine study was, absurd to say the least.
So those are comments on diversity and engagement then. Right, so perhaps we can address some other potential questions or issues related to the network. And I think one of the recurring themes that came up during the presentations were awareness of the resources and access to those resources. So I don't know if there's some thoughts on how one might improve or enhance the awareness of those resources and how they might facilitate completion of studies. There was some allusion, of course, to requiring them with respect to achieving funding. I think that was a very interesting strategy in terms of the probability of success of an approval of a trial for support being dependent on taking advantage of resources at impact, for example. But how might we be more effective, let's say, from the standpoint of the DMKRCC or the Pharmacometrics Clinical Trial Design Core, where I sit in engaging and that across. I'll throw that out for consideration.
I just start like for the DMKRCC. I think Sarah presented to MFMU and did a great job. And I don't want to speak in behalf of MFMU, but people are aware of the MPRINT and the resources. It becomes an issue is the need to engage in what, for MFMU studies, how can you leverage the resources that are available at the MPRINT. And we at Ohio State, we've worked with Sarah and then Pharmacometric Core on more than one project, and which led to larger to additional grant submissions and other projects. So I think that's happening. It's not at the level that it should be, partly because the MFMU went through the cycle, and now they're starting to get up and running with newer studies. And some of these studies may or may not need the MPRINT network, and that's where it becomes like, if you want to have translational aim, or if you don't need to do PKPD or use some of the cores, how can they make sure this MPRINT is actually on the table when this study is being discussed and presented? So that's one opportunity to do it.
So you suggest that the leadership of the networks then are aware of those resources in terms of helping to guide studies, and that there's a pre-assessment made in terms of the need in the first place of the resource, so that there's not extra expenditure of efforts where they're not necessarily required. So
I mean, I guess some PIs probably are aware of all the MPRINT cores and MPRINT infrastructures. Some of them may not be aware of it. So on one hand, you don't want to add additional steps in approving studies at the network, because there's a lot of steps to get them done. But on the other hand, I think there's some opportunities that if somebody's at the MFMU studies is doing microbiome studies, they're doing, they need phenotyping, they need pharmacogenomic study, they need any of these studies, can they work with the MPRINT and NICHD in a way to figure out how we can use these cores instead of going back to your parent institute and maybe using that facility?
So I guess that speaks to having maybe a set of rule sets defined for in-network and out-of-network interactions as well, and very clearly sort of outlined what sort of procedures might or not like would be in place. Sorry, Sarah, you're.
No, I was just going to say, I think, I've met with MFMU, PT, and I don't think I've met NRN because of since they've repurposed, I haven't met Improve. That's another one that we need to add to the list. So going to the network meetings has definitely been helpful, but also having a champion among those networks is another important aspect. And someone, like Majetta, MFMU, who could say, hey, why don't you reach out to MPRINT? They might be interested in, we're already enrolling patients into a clinical study where there's going to be drugs in lactation. Could we contact, the MPRINT hub at CET at UCSD and see if, they'd be interested in doing an ancillary study and maybe collecting some additional samples that we could then use to support further studies. And I think that goes beyond, what's in MPRINT as well, but, maybe the Transporter Consortium needs some clinical data to be able to do proteomics and so forth. And so trying to have those connections between different networks that can enable the ability to share resources and save resources would be important.
I mean, one mechanism would be, just to build on this, that there is opportunity to submit ancillary studies to the network. So if once you have studies up and running, and if there's any particular idea, then you can go in and present it. And right now there's not a lot of studies, but it's easy. We can have the BCC or someone from the network come present to the MPRINT about ongoing study and plan the study, so people can start thinking about leveraging the MFMU resources, and this large number of patients will be enrolled.
Yeah, and I think that comes back to what the MPRINT Hub website needs to be able to do too, is to point to the MFMU so that other networks could also find those resources and understand what studies are going on as well. So
I think Sharon had
I had a little bit of, I agree with those pieces, but I wanted to suggest something different or sort of a little different. So on the HIV side, the 4 HIV networks once a month have a call together. And we each get about, 5-10 minutes to talk about, hey, what's in the hopper, what's cooking, what's enrolling, and what's kind of finished going out to guidelines or something like that. It would be reasonable once a quarter to have the network PIs from these NICHD networks to have a call together. You get 10 minutes, no slides. Sorry, guys, no slides. And just say, hey, this is what we're doing. This is what's cooking and what we're looking for. Because I think that it's a bidirectional collaboration kind of thing that has to happen. I think, the leaderships of the networks have to know each other and talk to each other. I think that obviously the websites all need to reference the other ones and have easy kind of directions. Hey, you want to submit a newer concept sheet to Impact? Here's their website, go to studies, it's on the bottom. Have a good time. There's a link there, etc. So I think it's something on the website, but I think that if the leaders of the networks don't talk to each other, it's going to be hard to expect the investigators to know where to go and who to go. So I think that maybe from the NICHD side, you have, God knows, we're already on a lot of conference calls, but it may be reasonable to have once a quarter a cross networks kind of call.
So this is a little bit of a difference in the structure. We don't have like what you have with Impact, a leader of the network. So it's multiple people on the steering committee and the DCC.
But
so there is no there is no sort of lead PI.
Yeah,
what
but
we
that's
have,
okay. Pick 2 people, and those 2 people represent the network. They don't have to be the PIs of the network. They have to understand what the network is doing. That's all.
Well,
Yeah, I was just going to say, much to Sharon's point, we're actually starting that next Thursday. It's going to be our first one. We're asking the DCCs of our 5 networks participating in our initiative to come together on a quarterly basis to discuss topics. We'll see how it goes the first time around, but appreciate the idea. And like I say, we have it in place to start next week. So thank you.
but that's
We'd love to have MPRINT. In fact, I was thinking that as you guys were talking.
Yeah, so that's something I like. PTN's not part of one of those 5. Maybe they should still be included in it as well. So, and those that are, involved, Improve is another one, right? So.
Yeah, well, Improve is completely different because it's not a technical network. It's
But it's a resource that needs to be involved, right?
Absolutely.
And somehow, so, and maybe that's one of the spokes on our MPRINT hub is again, that Improve.
Zasha, did you have a comment to add as well?
I just wanted to comment that I couldn't hear the other end comments, but to address your question regarding constantly engaging with NIH funding sponsor. I believe the network studies, they have steering committees where that is it's business or discuss business related to the network. Does that?
Yeah, but I think it has to be a personal touch to it. I think that each of us kind of knows pretty closely what our networks are doing and what's going to happen over the next year or 2 years, kind of what studies are happening or what's difficult to enroll or some random stupid thoughts that are coming through. I think that that personal relationship, I want to say Sarah and I have our personal relationship over 2 years of texting and sending, oh my God, comments to each other and, stuff like that. And that makes a huge difference. So, this is a great, you've got representation from multiple interested, and we were so interested, we schlepped to Washington to get here. So, okay, we're interested. And this is the kind of starting point, MFMU says, oh my God, you do phase ones. I'm like, yeah, of course we do phase ones. That's all we do. Okay, we should have known that from each other, but this is the kind of thing we need to set up a, quarterly call and say, you need to, and if you can't get on it, who from your network is designated to talk for you and go from there.
And I'll add that it would be really helpful, I think, also to consider outside of NIH funded networks, how to grow that. I think about it as everyone hopefully has their, financial portfolio and how to diversify that. And I think that that's an important piece of this too, is to know how to diversify that portfolio, because it just can't be one network supported by an NICHD grant. So it has to be built out to different foundations. We've had discussions about the Gates Foundation for NICHD. It has to be built out with other grants. What George was talking about with partnering with basic scientists, that we know the NIH loves the mechanistic aim that can be achieved, or the pilot or aim 3 pilot study aim 3 that the basic scientist needs. We all know this the way that to kind of make it work. So that, I think that strategy, rather than just focusing on one pot of money, I think is a really important piece. And that starts a conversation that then organically you grow out of that.
I'll say that's also part of the goal of this meeting, was to bring lots of different networks together so we can have these face-to-face discussions. And, we invite multiple networks, and some are able to come and some are not, but at least it reaches out to them and say, hey, we're still here, we're still interested, and this is what we're doing. But there is definitely nothing like the face-to-face. And over the last 3 months, when I've been in DC 3 times now, that's where I've made the most connections in things that I haven't been able to make over 2 years virtually. So.
And then just one more thing at least for the MFMU, like these studies run 3 to 5 years. So, people didn't, and like I said, I think most people are aware of it, and then all these studies are published online. I think it's a good opportunity when people connect with each other to talk about what they're doing and how they can collaborate. But these studies are there and they stay for 3 to 5 years. So there's always opportunity to jump on any of the studies and submit ancillary studies, or ultimately be aware of what data is collected and what specimen collected, so people can plan for secondary analysis down the road.
Just to add on that, I would think kind of a council of networks, if that's what you want to call it, would be a great mechanism for disseminating information, so that a finding that you have in MFMU could be disseminated through the channels that all the other networks have, to get that information out to the public and to clinicians much more quickly because of the broader spread. And, I'll give an example. I'm going to guess that the PTN cuddle studies, that has a change in the label, that there isn't a big press release that goes out and says it's okay to breastfeed on oxycodone now. There would be, if it was not okay, that there would be a something like that. But that's a finding that should be disseminated, and it should be disseminated broadly and should be considered a win across networks.
So go ahead.
One aspect I was going to just add is, we've talked a lot about networking in terms of the clinical trial infrastructure, and I'm wondering if there's also opportunity, like with the knowledge base and things like that, for people who are doing smaller studies, whether PK studies or things like that, to have an opportunity to maybe instead of you looking for the data in literature, to be able to submit data for consideration or things like that, to sort of as something, if people are aware that's a resource where they're able to give you some of the data or their findings, that might be useful as well, just for our own knowledge base.
Yeah, and you know, the gold version knowledge base is all hand pulled. So anyone who can give us data would be very welcome, because you know, part of it is we would need to verify the data and make sure it meets our quality standards, but it also is something that does take time. And so we'd welcome collaborators on that, I believe.
So Elimika, just to clarify, are you proposing sort of a potential for like a portal where someone could ask a question and provide data, and it could be assessed and maybe directed to an appropriate resource within the network, at least for a sort of a triage evaluation initially?
I hadn't thought through it very well how exactly it would work, but yes, I was thinking specifically on the knowledge base and things like that. So just outside of maybe traditionally thinking about the clinical trials, what other, I guess, ways can other people engage, and maybe just some thought around that.
Question. That's okay. Hi, I'm Maureen Shin. I'm a clinical pharmacology fellow from UCSF. Thank you so much for your insight. I kind of have a slightly different focus on my question. I can only speak from my experiences as a pharmacy student at UCSF, but at least in our curriculum, we're exposed to a variety of specialties and all about diversity and equity. Yet regarding pregnancy and OBGYN, we are only given a 2-week curriculum, very high level of what's in the pregnancy category A, B, C to X. And despite all of the importance that is there, we have not been, I only was very recently exposed to this community and the resources. So my question is, if there were any initiatives or any barriers into bringing this resource into, I understand for early trainees, but even for emerging trainees while they're in school or they're in clinical rotations, what are some challenges that we can begin to consider as we think about educating emerging clinicians and scientists?
Yeah, I'm impressed you get 2 weeks. I don't remember getting that long in pharmacy school on pregnancy. But yeah, that is definitely an issue we have, is training in medical and pharmacy schools and nursing schools, and even beyond below that, because we're not providing enough information. And I think where you just said you got the ABC labeling category, so we're not providing up-to-date information either. Yeah, things that are no longer active, right? We're not providing contemporary information. And so I think that's another place where we can play a role perhaps in our training initiatives. And we have some initiatives we're looking at internationally that might help support this as well.
Yeah, and I will say that I just looked over at Shirley because at our School of Pharmacy, and I asked her, I kind of mouthed to her, how much do we do? And she said, we don't do much either, right? And I think in medical school, it's the same. And I think now with the change in the residency program that we all have, it's worse because you don't even have to do a NICU rotation if you don't want to. So you don't even have to go through the NICU, which is, to me, a tragedy. And a lost opportunity. I don't know how to tackle that one. I'm sorry to say. But I think maybe one option, and this is what I've seen, especially with our School of Pharmacy, I have to say, even more than our MDs, because our T32 program is mostly our PhD and PharmDs and not MDs. Our MDs, as much, I get the feeling, are not, even if they're subspecialists, the clinical pharmacology arm isn't as much of a calling. For our PharmDs, I think it's a big calling and a big opportunity to do academic work and not have to, use your degree to be a clinical pharmacist. And that's where I think the opportunity comes. That's where I think the training part of this, and to build it in somehow, is so key. Because I think that there's a population of people out there that are very smart that want to do this, but that we have to provide the resources and infrastructure for them to be able to do that.
So I think that's pretty an excellent point, an excellent observation. And I know we have a session on training tomorrow, right? Training. So as we're getting close on time, and I think our next presentation is set for 4. That I would like to thank all of the panelists for their input this afternoon, for a vigorous discussion, and the presenters for their visions for each of the 3 MPRINT components. So thank you very much. What's that?